Okay. So it looks like we have quite a few people in here. I'm back at the website and I'm looking at like the My Data page. And as you can see that there's links here I'm going to actually make sure to share my entire screen to make sure that this captures everything. So I'm going to go to the second extract that I created, and I'm going to go to the formatted data. So I'm going to right click on downloads data and save link as. Then I'm going to go to a folder where I know how to access the data later. And you'll notice that the data will be in a .dta.gz format. So that just means it has been compressed to save space, make it easier to download. And I like to use a decompression software called 7-zip. It's free, it's easy to use. So I'm going to extract my data, and then I can open it right up in Stata. And then you see all of the variables that we downloaded. And so I've already got a do file, so I'm actually going to close out and work with a data file that I created just for this purpose. So I have my data, my do file, and I will be making sure that this do file is freely available and accessible after the workshop, and I believe we'll be posting the recording as well. So I'm just going to change my working directory to where I saved my data. And then I'm going to open up, I had previously gone in and renamed that data file from PMA. And I'm going to open up my file. So I'm going to use that workshop data. Excellent. So, great. So first things first, whenever I open a data file, I like to get a sense of the content of the file. So I'm going to do a cross tabulation of those two versions of this result variable. So I want to take a look at how many women completed both questionnaires. So the column here is result FQ_1. So that's the result in phase 1. So if you recall, when we created the data extract, I chose just female respondents. So we're only seeing women here who completed or partially completed that first questionnaire. But we also get to see if she did not complete the phase 2 questionnaire, how come? So that's getting into what we'll do is discussing about loss to follow-up. And you'll also notice that we've got some missing cases here. We don't have a ton of time to go into that, but please check out our webinar that's more focused on like the details and format of these data, and that you can find that on ipums.org. So my next step is that I would like to keep only women who were interviewed in both phase 1 and phase 2. And we're not keeping only partially completed records, just completed surveys. So dropping women who are only interviewed in one or the other. Okay, and then secondly, when PMA constructs its briefs that they mentioned, they only analyze the de facto population. So that means they're going to be dropping women who are usually in the household but absent the night before, and they will include visitors who slept there the night before. So I'm going to keep women who were the de facto population in both phase 1 and phase 2. So you wanted to see what the codes were. So we've got the labels here, but you can take a look at the labels, or you can also go to our website and see what the numbers are to understand why I used the codes that I did. Excellent. Okay, so first we're going to go to the data visualization. So if we wanted to get a high-level look at contraceptive use in Burkina Faso and Kenya during this period, I want to categorize all of the women who were interviewed in both phase 1 and phase 2 into 4 different categories. So first I want to look at women who were not using at either period, women who were using in both phase 1 and phase 2. I want to look at women who adopted a method between phase 1 and phase 2, and then also women who discontinued. So I think we discussed CP_1 and CP_2. Category 1, these will be women who were not users because their contraceptive use status is 0 in both periods. And then for category 2, they were user in both periods. Category 3 will be the adopters because it went from not use into use. And then category 4 went from use to non-use. And I do want to emphasize that this will not capture women who may have used a method for a short period of time and canceled or discontinued her use before we see it show up, or it might we might not see women who stopped using between the period but adopted maybe a different method later on. But again, the data is collected in a contraceptive calendar format, so you can catch these cases if you use the calendar data. And then also for sake of clarity, we're going to create a label for those categories so we remember what each of them mean. And so first I want to make it easier to visualize these in Stata. So I'm going to create separate dummy variables for each of the categories. So I'm going to tabulate category and generate 4 dummy variables out of that. So now we had about 42% non-users, 32% users, about 16% adopted, and just under 10% discontinued. So a huge advantage of using the longitudinal data over cross-sectional is that we can observe women both taking up family planning and discontinuing, rather than seeing the net effect in comparing the MCPR between the 2 surveys, because we may have only just noticed a modest increase in family planning use, just like netting out the difference between adoption and continuation. But then we wouldn't really be seeing the movement in those categories. And just so we can get a sense of how Kenya and Burkina Faso differed, I've got a bar graph, and we'll just be we'll be comparing these categories between the 2 countries. So I'm using unweighted counts of women. So as you can see, there are a lot more consistent users in Kenya than there are in Burkina Faso, but this does not take into account that these samples have different sample sizes. And I just wanted to demonstrate the differences between these 2 graphs, that like it really matters about, gotta make sure to graph proportions because these will look a little different if we're not using the sums. So as you can see, the non-users are a huge portion of Burkina Faso, but you still see quite a bit of movement in both In both countries, you have a comparable segment of these women who adopted or discontinued. But again, these are unweighted proportions. All right, so I'm going to double check on the chat, see if there's any questions. Okay. Feel free to add questions in the chat. I'll try to check back in to see if there's any things that I should clarify or go back to. But for now, I'm going to continue on. So as we said, our simple logistic regression that we're going to focus on today is going to be on whether impacts of COVID had significant effects on whether women adopted a family planning method or discontinued their method. So I'm going to reuse categories 3 and 4 and just rename them to adoption and discontinue, just so it's a lot more clear and we don't have to memorize what 3 and 4 mean. And then I also want to take a look at one of our main explanatory variables of whether the household lost income due to COVID. And so this is what I was getting at in when we're creating the data extract from the website. So we have this NIU category of not in universe. So these are women who lived in households that did not lose income because women were only given this question in their survey if they reported that their household did lose income. So for the purposes of this analysis, what we wanted to do is look at, did the household lose income or not? And then also, was it due to COVID? So we kind of have 3 categories of women here. If CV income loss is no, that means they did lose income, but they said it was not due to COVID. We have women who said their income was impacted and it was due to COVID. And then women who said, my household did not lose income. So we have 2 choices here. We could either make this into a 3-category variable and put that into our model. But for the sake of simplicity for today, the choice that I'm going to make is I'm going to group women whose household did not experience income loss with the women who did experience income loss, but it was not due to COVID. And again, probably, like not a choice you might make in a paper, but this is just more, it's easier to interpret a binary for the purposes of this workshop. And I did want to demonstrate a little bit, again, just in a different way to make sure that it's clear what I mean by the not in universe. So the variable HH income loss amount, that is whether the household experienced income loss due to COVID. So if the household did not lose income, then for CV income loss, they are not in universe. So what I'm going to do is recode our explanatory variable CV income loss to 0 or to no if the household income loss was equal to none. So that 3,904 is now equal to 0. Okay, excellent. And I do not see any questions in the chat, so I think I'm going to keep going. Let's see here. So, I also wanted to look at our other potential explanatory variable about COVID concern. So one reason why COVID concern could be, it's a proxy for the stress a woman might have about getting COVID, which might prevent her from going out to seek care, or it may affect her desire to have a child soon. So the paper that we are loosely basing this workshop on also use variables such as whether the household is experiencing food insecurity due to COVID, and also whether the woman was able to social distance, and then also available or a variable whether the household income recovered from that initial income loss due to COVID restrictions. So as you can see with the concern variable, a large majority in both countries, again, these are unweighted counts, were very concerned with another group being concerned, the not concerned and little concerned, pretty low categories. So there could potentially be large impacts here. So it seems like the women in these samples probably knew we're getting a lot of information, a lot of messages about COVID, experiencing a lot of impacts due to restrictions. So one thing you probably noticed is that what IPMS does with non-response or not in universe is we recode those to be rather large numbers. So for example, with the income loss variable, we use NIU, and I want to show you that. So we have our no and yes, and then we have larger numbers above 90 to kind of group these other categories. Is we're not going to include these in our analysis because they're missing, or that we don't have a valid value for them. So I have a loop here to remove all missing or not in universe codes out of our main variables to just make them missing if they are NIU or not missing or not known or don't know. So I'm just going to run that to make things very clean. And I also run it through so we get both the phase 1 version and the phase 2 version. Okay, let's see here. All right, we've been here for about 20 minutes. So we've got about 10 minutes left. And I want to establish that the sample design of PMA is a survey, and it's a multi-stage cluster. So I'm going to include the primary sampling unit in my my weighting survey set, and we also have the primary sampling units were selected according to strata. So I'm going to include that and also declare that panel weight is the weight that I want to use to get representative proportions. So I'm going to run that. So to get a cross tabulation with a weighted proportion, then I just insert the SVY colon ahead of my cross tabulation or ahead of my logit. So I'm going to run both an unweighted and a weighted cross tabulation of how many women adopted family planning in both of these countries, and then the weighted version, just to compare the differences. So in the non-weighted, we have 15.77% of this grouping in Burkina Faso adopted and 16.12 in Kenya. As you can see, there was an oversampling of women who adopted in Burkina, a little bit of an undersampling in Kenya. So we've got little, so we have a bit of a difference, not wildly different, but still corrected for attrition and those other features that those weights control for. Excellent. So I'm also going to create an age category, categorical variable, the way that the CARP paper did. And I'm also going to include a categorical for parity, so grouping the number of births. And then finally, I'm building my model. So I'm going to have separate regressions for each country. I'm not going to pool them together for this analysis because each country's COVID restriction experience was different. So I'm going to have separate models for adoption and discontinuation, and also by country. So that leaves us with 4 models. So I'll got a lot of things going on my screen, so I've got to, all right, so we have, I need to just copy this and actually paste it into Stata. Hopefully it's a little more visible. And I'm restricting to Burkina Faso for this one. So I've got, we're estimating the probability that the woman was of non-users in the first phase, whether she adopted in the second phase. So we've got our age recode, her urban status, her wealth tertile, her education level, whether her family lost income due to COVID, and then whether how concerned she was about contracting COVID. And then we're going to get the odds ratios, so it's a little easier to interpret. Okay. So because of limited time, I won't go through each of the control variables. And of course, there are plenty others that we could be including. But I did want to focus a little bit on our explanatories. So unfortunately for Burkina Faso, these are not, they're not significant statistically, but we do have the magnitude or the direction of the point estimate is somewhat interesting. So if this was statistically significant, we might interpret if the woman's household lost income, she might be a little bit more likely to adopt a method. Perhaps her demand for having a child soon was affected by the income loss, but it's not clear here. But this is room for more investigation. Perhaps there are things that we aren't controlling for that we should be. There'll be some admitted variable bias. Okay. And then next I want to take a look at Kenya. So I'm going to switch to restricting to country 7. So this is Kenya. And again, I'll not interpret the control variables, but for Kenya, and this is consistent with the CARP paper that we're loosely basing this on, even though we're observing the same woman even months later, there still seems to be an effect of how concerned she is about contracting COVID. The reference category here is not concerned at all. And of course, you know, this warrants some extra digging. It's interesting that it's only significant between women who are not concerned at all and a little concerned. So if she was a little concerned, she was much less likely to adopt than a woman who is not concerned at all. So that could be, you know, she did not want to go out to a facility and go adopt a new method. It's who knows, but there's plenty of variables in PMA that you might be able to dig into that. And now let's run those same models, but with discontinue instead. So once again, with Burkina Faso, not a lot going on with these like COVID impact variables. But again, there are lots of different COVID impact variables in these data. And perhaps there's something about the way that COVID restrictions rolled out in Burkina Faso versus Kenya that determine the impacts. Okay, and then with Kenya for discontinuation, we once again see that the concern variable was significantly significant compared to, so women who were not at all concerned compared to, well, women who were concerned about getting COVID compared to women who were not at all concerned were far more likely to discontinue a method. So that's consistent with the adoption results as well. And I think we have just very, we only have a few minutes left, I believe. So I'm gonna see if I look in the chat. Okay, can you talk a little bit about why you are not using clustered standard errors? And then, okay, so okay, full disclosure, I'm an economist and I'm not a PhD, but my understanding is that we are adjusting the standard errors according to both the primary sampling unit and the strata. So my understanding is that we are using clustered standard errors. However, that's definitely something that if you would like to email us separately about, we are following the briefs that PMA produces about these data. So we'll definitely have to get back to you on that. But this is, my understanding is that according to this multi-stage clustered sampling design, we're adjusting the standard errors based on strata and PSU. So, okay, awesome. Yeah, I'm not exactly, okay, great. So why are the baseline explanatory variables? I guess I'm not entirely sure about this question. Oh, why baseline explanatory models into the model. Okay. If I'm understanding correctly, you're asking why we're using like the phase 2 versions of each of these. So, okay, we have 2 minutes left. So for most of these explanatory variables, we are using variables because like the baseline happened before COVID, so that we couldn't, they couldn't ask questions about COVID impacts before COVID happened. So we are only using baseline 2, but you could, of course, like see if there was any changes in her education. So you could look to see if there were differences between her education at time 1 and time 2. But I just chose to use the time 2 because that's like, we were kind of looking at how she's changing over time. But again, a lot of the choices I made for this model was the sake of simplicity in this model. But the great thing about these data is that you have the information about this woman in both time periods. And if you, in this way, you can kind of dissect that change over time. I hope that's what your question was getting at. But definitely feel free to email ipums@umn.org and we'll post that. That's our user support email. And you can definitely, they'll be able to forward me questions that you have about this workshop. Sorry that we're kind of running a little low on time, but thank you so much everyone for attending and for your questions. So I think we'll be brought back to the larger group very soon.
All right, so I think we probably have everyone back from sessions now. So Matt and Devin, any notes, anything you want to note from the breakout sessions?
No notes, Phil, other than my session had no time for questions. So if anybody would like to ask a question, here is a great time to do it.
Yeah, no notes here, but same, if there's any other questions that came up, feel free to write them in the chat.
That's right. So I think you all should have access to the chat. So we did want to allow a little bit of time for questions. So if you have any, please feel free to put them in the chat and we can answer them right away. All right. Well, not seeing any questions, that's okay, because we'll have time for questions later after this session. But just a few more things to note before we finish up. So first of all, the examples that we ran through today, we're looking at the impact of COVID-19 on contraceptive use. And that's obviously only one of many topics that PMA collects data on. So PMA, we also collect data on topics like women's economic empowerment, women's sexual and reproductive empowerment, and reproductive histories. We collect a 2 to 3 year contraceptive calendar, a lot closer to 3 years than 2. Gender-based violence for certain countries and rounds, fertility and contraceptive preference and intentions, family planning service quality, and we also have GPS coordinates that are displaced for all of our participants and households. So these are only a few of the topics that we collect data on. Our survey instruments are actually available on the PMA website. So if you go to PMA's website and you go to the survey methodology tab, then you can find all of our survey instruments from phase 1, phase 2, and then we'll be posting phase 3 survey instruments shortly. And what I have here up on this slide, these topics, most of them are available for longitudinal data analysis. There's 1 or 2 that we've changed over time across phases, but for the most part, you can do longitudinal analysis of things like empowerment, reproductive histories, and fertility intentions, and so on. So I do see a question in the chat. So one question for the IPUMS team: what are the steps to registering for IPUMS data?
That's a great question. So on our website, so I had scrolled on just a little bit and clicked a button that said get data. Right immediately to the right of that, there's a button that says registered here. And just to reemphasize, always free to access. So just register, tell us a little bit about how you plan to use the data. And then I try to read those with like almost every day that they come in. So within about a business day, I'll be able to read it. As soon as you receive an email from us that your registration was approved, then you can go ahead, log in using your credential, the password and email you used, and you can go ahead and download the data right away.
All right, and thanks very much, Devin. Second question is IPUMS the preferred way to access PMA data? So very good question. So for right now, you can access the data either through IPUMS or through the PMA website. And either ways are perfectly acceptable. The data are in slightly different formats across these 2 modes of accessing them. But you won't have any difficulty doing analysis with either data set. So you could use either the PMA website or the IPUMS PMA website for accessing data. So a few other notes about our longitudinal panel data. So baseline panel data are available for all 8 countries right now. And as I just mentioned, they can be accessed through the IPM's PMA website or the PMA main website. The links are shown here. And we have 2 phases of longitudinal panel data. So we have baseline and follow-up available and posted online for Kenya, Nigeria, DRC, and Burkina Faso. And then this summer, we'll be posting data for Rajasthan, India, Uganda, Cote d'Ivoire, and Niger. So by the summer, we'll have panel data for all 8 countries where we work. And then shortly afterwards, we'll also have phase 3 data. So Kenya and Nigeria will post phase 3 data by August this year, then followed shortly by Burkina Faso and DRC. We referred to some of the research that PMA has done with these data, or that has been done with PMA data, but we've done obviously more research than what was just presented here. And if you want to look at more of our research, you can access it through the PMA Google Scholar website. And there's a link on this PowerPoint that we'll make available after this session. Next slide. So if you have questions about anything we presented today, we encourage you to email us. You can reach us through these 2 email addresses here. The first is the general email address for PMA, and the second is for IPMS. So any questions that you have, please feel free to reach out, and we'll answer your questions very shortly.
I had one that came up in the chat that I'd kind of like to touch on if this
Great.
would be a good time. Someone asked any takeaway messages from this analysis on what might be the key things to look for as far as the impact of COVID-19 on family planning use. And one thing that comes to mind that I meant to talk about in the breakout session, but we saw in Kenya that concern over COVID infection was a significant determinant of adoptions and discontinuation. So I feel like a takeaway could be to use the other variables that we didn't discuss in the breakout sessions to kind of narrow in on why was that. And there are variables in PMA about whether the woman tried to access healthcare and ask the reason, not just about family planning use, and whether she had any obstacles or difficulties accessing care during restrictions. So kind of narrowing in on why that might be the case, or why we didn't see significance about household income loss, things like that. So the data is really rich. So definitely go in and explore on the website.
Thanks, Devin. And just adding to that, if you're interested in some of the results that we have on the impact of COVID on contraceptive use, we do have a few papers on that have been published, one of which we referred to earlier. And overall, we found that in our geographies where we have data from before and during COVID, we did not see significant changes in overall contraceptive use at the population level. We also found that at the individual level, women were more likely to adopt contraception than they were to discontinue. So this was contrary to what was expected, that overall we expected to see pretty large impact of COVID on contraceptive use, but we didn't see that at the population or individual level. But as was illustrated in this session, there's variation among women by their fear of COVID. So the story is somewhat more nuanced than just the overall population level. And like Devin said, we're really just scratching the surface of the analysis that we can do with PMA data. So I think there's much more that can be done. And I see another question in the chat. What caveats do you add to ensure one appreciates that some of the PMA data are regional within countries and not national, like Congo, India, and Nigeria? So that's true. So we don't produce national estimates for India, DR Congo, or Nigeria. So the data that we have are representative only at the subnational level. So we can't make any statements about national level estimates of COVID or family planning for those geographies, but we do provide data at the subnational level, which I think is we found is valuable for programs, family planning, government activities, and other purposes as well, including research. So more information about where our data are represented is on our website. And also, like I said, we'll make this presentation available if you have more questions. All right. Great. So if there are no more questions, we want to thank you for attending this this webinar. We really appreciate your interest in our data. And again, if you have any questions, please feel free to email us at the addresses I mentioned in the previous slide. And thanks very much once again.